Go ahead, Shaun.
Good afternoon, everyone. My name is Dushan. I'm from HCA, one of the relationship managers. We have today Professor Shaun, Preston, and Mr. Sheth from HCA who are going to do a talk for us. I'm going to just do a quick introduction from everybody, and then everyone, Mr. Preston and Mr. Shaun, have about 20 minutes of their presentation. We also recording this session so we can send certificates to everyone. And if you have any questions, please leave them in the chat, and I'm gonna read the questions out loud in the end, and then we consultants, they're gonna answer all the questions for you. So first of all, we're gonna have Mr. Sheth. He's a consultant laparoscopic upper GI surgeon. He's have an extensive expertise in condition affecting the stomach, liver, gallbladder, and pancreas. And his particular interest is in anti-reflux surgery, hernia surgery, and a laparoscopic surgery include bile duct exploration. Without further ado, Mr. Sheth, please, you can continue with your presentation if you want.
Thank you, Dusan. Welcome all. I'm just going to start sharing. Okay. Thank you, Dusan, for the introduction. My name is Hemant Sheth. I'm a consultant upper GI surgeon. I work for London Northwest NHS Trust. Gastroesophageal reflux disease is a very common problem. I think maybe 2 out of 5 of us will suffer with reflux at some point in time. And reflux can be manifesting in various different ways. It could be increased reflux of food or food material, a bitter taste in the mouth, and it results from increased acid of food coming up or change in the quality of the reflux juice, or sometimes the inability to clear the content of the stomach effectively, or a combination of these factors. As I said, it's a very common problem. 20% of the population will suffer with heartburn at least once a week. The estimated prevalence of gastroesophageal reflux disease is approximately 0.36% of the general population, and it represents up to 80% of the benign esophageal pathology. Various predisposing factors, some genetic factors being attributed with an increased incidence, which is seen in identical twins. Hiatus hernia being the commonest predisposing factors. Certain lifestyle factors like smoking, obesity, increased alcohol consumption or abuse, coffee and chocolates. Helicobacter pylori is an interesting pathophysiological correlation. Eradication is supposed to increase the response to PPIs, and it's also supposed to help in the management of the medical management of the reflux disease, but there is no clear-cut evidence regarding the complete benefit from eradicating H. pylori and its direct effect on reflux disease. Sorry, it's stuck. Chronic H. pylori infection is associated with increased risk of peptic ulcers and a gastric cancer. And current guidelines do say that H. pylori eradication, irrespective of the potential effects on GRD, is definitely recommended. Physiological reflux is something which is fairly common, as seen during childhood, pregnancy, usually immediately postprandial or in association with gaseous irritations. People who have large volume food or high fat content also are more prone to getting reflux often. Pathological reflux is seen predominantly due to failure of the overall natural anti-reflux mechanisms, and these can be sort of broken down into a few factors depending upon the organ involved. So the esophageal factors are most commonly due to a defective lower esophageal sphincter and concomitant presence of the hiatus hernia. Along with this, a loss of intra-abdominal length of the esophagus, which is less than 2 centimeters, is generally considered to be significant. Why this is so important is because it contributes to the major competency of the cardia, that is the total length of the intra-abdominal esophagus, along with the resting pressure. 25% of patients with mild or almost 50% of patients with severe esophagitis had either failed or hypertensive peristalsis, which sort of tends to contribute to the reflux disease. Among the anatomical factors, there is the angle of His, which is the angle between the esophagus and the stomach. An abolition of this leads to a straightening of the esophagus, getting it pulled into the chest, worsening the reflux, and a poor action of the diaphragmatic crura and the lower esophageal sphincter pressures. Gastric factors, predominantly like gastric motility, delayed gastric emptying, maybe particularly in diabetics, may have a positive effect on actually promoting reflux disease. Gastric outlet obstruction, in particular, can also exacerbate reflux symptoms. And in this way, fundoplication seems to help the most because it tends to enhance gastric emptying to an extent. Increased gastric acid secretion particularly contributes to pathophysiology of reflux and has been found to, patients suffering with reflux have been found to have a mean increased basal acid output. Symptoms of reflux can vary, the most typical being heartburn, regurgitation, epigastric pain, retrosternal pain, but they can also present with atypical symptoms, more often like chest pain, dysphagia, hoarseness of voice, affecting the dentition, nocturnal wheeze, or asthma. And sometimes it can be because of halitosis or completely asymptomatic. There are various diagnostic tools that we use to diagnose reflux, and one of the cornerstones is endoscopy. The advantages of endoscopy are it helps in direct visualization. It documents the presence and the severity of reflux. It can also detect other complications associated with chronic reflux disease, presence or absence of Barrett's, and also helps us evaluate to some degree any concomitant gastric and urinary pathology. It is usually useful in all patients with upper GI symptoms, particularly so by prior to anti-reflux surgery. And most anti-reflux surgeons would prefer to actually perform their own endoscopies prior to contemplating any kind of fundoplication. It's important to note that severity of symptoms do not always correlate with the presence and severity of esophagitis. In other words, you may find grade 3, grade 4 reflux, but the patient do not have the degree of symptoms that correlate with the degree directly of the esophagitis. It is also mandatory that patients get an adequate trial of PPI prior to endoscopy. This is generally true for patients less than 55, but over the age of 55, if the symptoms are significantly worrying enough, then a direct access to endoscopy might be useful. The second most important cornerstone of assessing reflux disease is esophageal manometry, which is an invasive test similar to endoscopy, which involves measuring various aspects of the function of the esophagus, including the lower esophageal sphincter, the presence or absence of esophageal dysmotility, and from a surgical perspective, whether there is any degree of symptom correlation. It is the most sensitive test for detection of excessive esophageal acid exposure. It allows you to have a composite score and is an objective parameter on which we can base our decision to operate or not to operate, with a very good sensitivity and specificity and overall accuracy. It is simple, it's inexpensive, it can be uncomfortable, and there are a group of people or patients who will probably not tolerate the presence of a 24-hour probe. Other alternatives to evaluate this would be a Bravo capsule examination. So how does the 24-hour pH manometry help us? It would be helping us in establishing a definitive diagnosis of gastroesophageal reflux disease with normal endoscopy, particularly if there's failure of appropriate medical therapy and prior to immediately after surgery or in association with other complex esophageal disorders. What are the complications of reflux? So erythroesophagitis ulceration can be a marker of severe reflux. There is a recurrence rate, which is very high, particularly with erythroesophagitis, especially after stopping PPI. But sometimes it's important to remember that often the severity of symptoms do not correlate with the grade of esophagitis. Successful outcome from surgery also depends on the presence or the grade of esophagitis. Barrett's esophagus, again, something that we see in patients with long-standing reflux. The longer the duration of reflux, more is the prevalence of Barrett's. And there is a higher prevalence in patients with a defective lower esophageal sphincter, usually in association with impaired esophageal motility. While fundoplication does provide reliable, reproducible relief from symptoms, there is no correlation between fundoplication and healing of Barrett's. It is useful to avoid other complications of reflux disease and for symptomatic management. Strictures of the esophagus due to chronic reflux, a well-known complication, can happen while the patient is still on medical treatment, can coexist with Barrett's mucosa, and patients may require repeated dilatations. Interestingly, peptic strictures are often associated with esophageal shortening. Surgical treatment makes it more challenging because we may need to do some form of plasty in order to increase the length of the intra-abdominal esophagus. Also, due to the periesophageal inflammation, overall dissection can sometimes be a bit tricky. Is there a direct link between adenocarcinoma? While there has been an association of long-standing reflux with an increased incidence of adenocarcinoma, there is no direct causal link as such. The odds ratio does suggest that if you have chronic untreated reflux, you are at a higher risk of developing an esophageal adenocarcinoma. While medical treatment may provide some benefit, however, there is clear lack of conclusive evidence regarding definitive risk reduction. Surgery, again, offers a relief from symptom progression and may be able to alter the course of the progression of the reflux to adenocarcinoma. The cornerstone of reflux management, according to me, is medical management and lifestyle changes. One cannot be more emphatic about how important this is. Weight loss is the single most important factor. Even if the weight loss does not take away your reflux symptoms considerably, it will increase the chances of any surgical intervention that may be required. In general, I would be very hesitant to offer anti-reflux surgery in patients with BMI of more than 35, for example. In my current practice, I set them a target BMI of at least less than 30 prior to actually offering them fundoplication surgery. Exercise, particularly heavy exercise, weightlifting, repeated bending or stooping may exacerbate reflux symptoms. Dietary alterations are mandatory. Fatty foods, alcohol, smoking cessations. I tend to advise my patients and tell them that they should follow what we call a no-C diet. By a no-C diet, I refer to any food articles which begin with the letter C, so something which is fairly common. Things like cheese, chocolate, cakes, curries, Chinese, crisps, cream, coffee, cigarettes. Of course, there are exceptions to the rule of C's, and those exceptions include C for chicken is acceptable as far as it is not fried or like a fast food KFC chicken, and fish is acceptable as far as it's not fish and chips. It's also important to stress to the patient that they need to change their lifestyle and focus on eating small and frequent meals, and that the last meal should be at least 3 hours prior to resting or retiring or prior to any kind of exercise. Elevation of head end of the bed is useful, particularly in smokers, but there is no long-term benefit on its own. The second cornerstone of medical management remains PPIs. PPIs are known to help heal esophagitis, especially particularly as compared to H2 receptor antagonists. And not only do they provide better symptom relief, but accentuate the healing of esophagitis. Acid suppression also helps in 24 reduce intragastric volumes, increase gastric emptying, and decreasing the volume reflux. It's also important to note that the effect of PPI does not actually decrease with time, and symptom relief and esophagitis cure rates are above 90%. And current evidence suggests that PPIs have been shown to be effective for up to 11 years of continuous use. Children generally require a higher dose than adults, and the optimal mode for PPI administration at the moment is once per day. What I tend to recommend to my patients is that I start off with a BD dosage. That's 1 in the morning, 1 in the evening. And I generally tend to recommend the patients that the morning dose has to be taken as soon as they wake up, even before they brush their teeth, because the taste of the toothpaste in the mouth and the thought of food can also get your acid pumps going and increase the acid secretion. And the evening dose is usually half an hour before the evening meal. After the first 2 weeks, the PPIs can be reduced to once a day, and that depends upon the symptom diary which the patient will come up with, whether the symptoms are worse in the night or whether they're worse in the day. Evening dose is particularly indicated in atypical reflux or patients with motility disorders and patients who have persistent symptoms. We don't have to make the patient completely achlorhydric in order to heal the esophagitis. And during the day, acid suppression will help in healing the reflux and associate that with symptom relief. H2 receptor antagonists have been used, were the mainstay prior to the advent of PPI. Nowadays, in some patients with severe reflux or patients who have represented with reflux after previous surgery may benefit from H2 receptor antagonists in conjunction with a promotility agent or other antacids. There are other endoscopic techniques which vary from a strata procedure, which involves the radiofrequency induction of thermal energy at the lower esophageal sphincter, which kind of gives rise to a stricture towards the lower end of the esophagus, preventing acid reflux, like the Lynx devices or the EndoCinch devices. None of these newer endoscopic techniques have shown evidence of long-term benefit. They've definitely shown benefit in the short term with excellent immediate and short-term results, but current evidence would suggest that these devices should be used within a clinical trial setting. There is an increasing uptake of the Lynx device in specific group of patients with a lax lower esophageal sphincter, which is exacerbating and leading to volume reflux rather than a true hiatus hernia. Surgical indication is predominantly when there is failure of medical management or there are complications of GORD, particularly aspiration pneumonias, recurrent reflux, asthma, or sometimes as an adjunct with bariatric surgery. It is particularly useful in children with mental handicap or where there is evidence of malnutrition due to chronic reflux. Patient choice over lifelong medical therapy. If patients have concomitant reflux and gallstone disease, I prefer to offer a cholecystectomy in the first instance. And then if the reflux symptoms persist in spite of the cholecystectomy, they could be potentially considered for anti-reflux surgery. Anti-reflux procedures are also performed in conjunction with Heller's cardiomyotomy as a part of achilles surgery. And the basic principles are to achieve a good repair of the hiatal crura, restore the intra-abdominal length of the esophagus, and to perform as loose a wrap as possible to reduce the risk of postoperative dysphagia. Most surgeons would anchor the wrap to the lower esophagus in order to prevent the slippage of the wrap back into the chest. The primary action is the floppy valve principle. It reduces the ability of the stomach to become very big, prevents the fundus which is used to wrap, and therefore can promote gastric emptying and reduce the volume of the gastric contents. And it also prevents the shortening of the abdominal esophagus during gastric distension. The gold standard for fundoplication, which I think most surgeons were first trained, was a Nissen 360 fundoplication, which is so-called the classic Nissens. Essentially, the intra-abdominal length of the esophagus is restored, a hiatal crura dissected. There may be a need to mobilize the short gastrics. The vagus nerve is identified and preserved, and the stomach is wrapped in a 360 fashion around the lower 1/3 of the esophagus. There are various modifications to the Nissen's fundoplications. Each one of them have shown good acid control and symptom control over a period of years. Partial fundoplication, the rationale being to reduce the incidence of overcompetence of the cardia and prevent dysphagia. Partial fundoplications can be an anterior 180 or a posterior 180 or even a 270 wrap. A door anterior 90-degree fundoplication is used in conjunction with a Heller's esophagocardiotomy. This is usually in conjunction with achilles surgery. A modification of the 360 fundoplication or an anterior fundoplication is a Watson repair. And of late, more and more surgeons are performing either the anterior Watson repair or a posterior 180 repair. Overall, the surgery is very well tolerated with a very low morbidity, mortality, and fewer complications. Among the main complications to be worried about would be a wrap which is either too long or too tight, or sometimes a slipped wrap, particularly with a Nissen's fundoplication. During surgery, there is a risk of damaging the pleura or even damaging the esophagus or the stomach, and in very rare circumstances, damaging the spleen. Incisional hernia is extremely rare because the surgeries are done laparoscopically or in more instances nowadays robotically. There could be potential for chest complications like chest infections or atelectasis, and persistent dysphagia can occur in up to 5% or more of individuals, with gas bloat in 2 to 5% of the individuals. Diarrhea as a symptom can be seen in up to 20%, while dumping has been reported in 20 to 30% of the patients. These are the results from the various different types of surgical interventions or reflux repairs, with Watson having the highest rate of symptomatic satisfaction. And some of the published theories from the laparoscopic fundoplication from various surgeons around the world. This is one of the largest series of results of laparoscopic fundoplication. You can see very low morbidity, mortality less than 3%. However, the postoperative dysphagia, gas bloat was significantly high. Reoperation rate was extremely low, and especially for recurrent symptoms, and patient satisfaction was approaching close to 100%. There is a significant learning curve associated with the surgical technique, and the modern day fundoplication involves a short, floppy fundoplication. I don't think most surgeons use the esophageal dilator or a bougie anymore. And as far as possible to prevent mobilization of the short gastrics and approximation of the hiatal crura. Why was the partial fundoplication found to be more beneficial? It was thought to be more physiologic, less likely to cause the dysphagia and gas bloat, and improve the esophageal peristalsis. Particularly useful for patients who have a background of esophageal dysmodality as detected by the 24-hour pH manometry. And these are some of the results from laparoscopic Nissen versus anterior fundoplication. Overall patient satisfaction was comparable in both the groups, and the reoperation rate was less than 7%. What is the evidence for surgery versus medical management? Interestingly, surgical management has been associated with a better result, symptom control, particularly in the early days at year 1 and year 5. interestingly, by the time you come to year 10, there is not significant difference between patients who have been managed purely with medical management and then PPIs versus surgery. There's a low failure rate, and redo fundoplication can be considered. But redo fundoplication has to be performed by experienced surgeons because they're associated with even a lower rate of success. Recurrent gore following fundoplication, again, maximal to the PPI therapy is the first line approach. And laparoscopic approach is still preferable if previous approach had also been laparoscopic. Commonest cause of failure is a slip wrap, followed by a misplaced wrap. And in proper expert hands or experienced hands, it is successful in 93% of cases. Atypical reflux, or so-called NERD, or non-erosive reflux disease. It's very interesting and a newly identified entity, which is still, the exact pathophysiology is not very clear. Patients do have an abnormal acid exposure time and can have abnormal pH manometry results or have increased hypersensitivity of the lower 1/3 of the esophagus. If the patients have typical reflux symptoms but have normal pH study, that's a purely functional reflux. There is no gold standard test for diagnosis. Trial of PPI is considered still to be very beneficial and remain the mainstay of therapy. Response to treatment is generally poor as opposed to erosive reflux dyspepsia. And on-demand PPI is often the most cost-effective treatment option. Surgical treatment has been found to be suboptimal and careful patient selection is advocated. Nighttime reflux, particularly in the obese with high BMI, hypertension, obstructive sleep apnea and asthma, nasopharyngeal symptoms abound, and particularly PPI therapy in an evening dose is again found to be more useful. So is reflux disease, the traditional concept was it represented a group of symptoms which progress through various grades from esophagitis to Barrett's esophagus to end-stage reflux disease. This concept has a profound effect on management, but recent epidemiological evidence suggests otherwise. There is very rarely natural progression from mild to severe disease, especially if patient education and lifestyle modifications are instituted early on. Often, not all patients have the same outcome. The esophageal physiology and mucosal biology are not shared across the spectrum. The response to treatment, risk of malignancy is different in the different patient groups. And therefore, this new model shifts the focus to more esophageal symptoms. So to conclude my talk, I would say that operation should not be the first line therapy for majority of reflux patients. Disabled esophagus with an inappropriate or dysfunctional fundoplication is a terrible price to pay for control of acid reflux. And generally in adults, a predictor of good surgical outcome is the response of typical symptoms of reflux to PPI therapy. Thank you.
Thank you so much, Mr. Sheth. For anyone that actually joined a little bit later, you can submit your questions in the chat, please. We're going to just move on now with, and then I'm going to introduce you, Professor Shaun Preston. Just want to say that Mr. Preston is a general surgeon and head of oesophagus gastric unit at the Royal Surrey NHS Foundation Trust Hospital. He also specializes in upper GI surgery, keyhole surgery, and endoscopy. His areas of interest include management of reflux, Barrett esophagus, gastric cancer, hernia repair management, and gallstone robotic surgery. And Mr. Preston is going to talk about robotic surgery in this talk. Over to you, Mr. Preston.
Thanks for the opportunity. I'm Director of Upper GI Surgery in for the Surrey and Sussex Cancer Unit. I also work with the robotic surgery at Lister and robotic surgery for HCA at Guy's. So robotics is no longer a future dream. it's here and it's here to stay. Next slide, please. So historically, robotics have been confined to gynae and urology. They have a high caseload, limited field of view, and low levels of complexity. Upper GI is the complete opposite of that. But as time has progressed and units have grown, then the next slide, please. Then other other specialties have come on board. The growth in robotics is enormous. Even in the UK now, the growth is almost exponential. It's increased 45% across 12 months, 23 to 24, and it increased 12% within 3 months from 23 to 24. The expected growth is from 8 billion in 22 to 36 billion in 2032, and that's probably a conservative underestimate. Next slide, please. So the benefits of robotic surgery over standard laparoscopic surgery are that the instruments, instead of being straight sticks that only rotate along one plane, the instruments are articulated. The movement mirrors the movement of the surgeon's hand.
So sorry, Mr. Preston, just going to interrupt for a second. Alec, we can't see the slides. Sorry, Ariana can't see the slides. Is it something we can change? So sorry, Mr. Preston.
Worked earlier, didn't it?
They were on my screen, so that actually might be someone individually. And there, I'll share again.
Let's check that everyone can see it before I start.
Can everyone see it now?
It would probably be on the okay,
good.
yes. No worries.
Thank
Please
you.
continue.
Are okay?
Yes, you can continue,
okay?
Shaun.
Yeah, great. So the benefits are articulated instruments. The ratio between the hand movement and the robotic movement can be adjusted, so you get particularly fine movement. One of the great benefits I find is that you get immersive 3D imaging certainly with the Da Vinci system, not with all systems, and that is an absolute game changer. And this is the way that things will move. It's like being in the abdomen or in the chest doing the operation. It's also much more comfortable if you're sat for long periods of time operating with a robot than standing with in a praying mantis type position trying to suture laparoscopically. Next slide, please. So most people don't really understand what robotics is. It's actually a master-slave system. It's not the robot doing the operation, it's the surgeon doing the operation. So we dock the robot over with instruments in the abdomen or in the chest, and we sit on a console and control the robot with the surgeon sat by the bedside, an assistant anyway by the bedside, using both hands and feet to control the camera. And instead of having 2 hands for the surgeon, you have 3 hands within the robot, which you control the interplay between the two with your feet. Next slide, please. So is there any benefit in benign upper GI surgery? So in standard Nissen fundoplication, probably not. It's just a more expensive way of doing the procedure. But this is a high volume procedure, and it's the way we train in more complex operations. And actually, I don't perform a Nissen. As we heard earlier, there's evidence for a partial fundoplication. I do a TPE, which is 10 stitches as opposed to a Nissen, which is 3. And suturing is a dream. And once you get used to that augmented 3D immersive view, it's very, very difficult to go back to standard laparoscopic surgery. Next slide, please. And again, and again, and again. The benefits, though, really come when you get on to either revisional hiatal surgery or giant paraesophageal hernias. This is a case where we have the whole stomach up in the chest. The patients are often breathless, not always experiencing reflux. You can see the significant cardiac compression, which is the cause for the breathlessness, pressure on the atria rather than occupation of space of either lung. And here, robotic surgery is of great benefit. The operation times are less, there's less blood loss, And even in revisional surgery, the times for operating are less, and the reoperation rate is lower. The view is superb, and it's undoubtedly the way to go forward with these procedures. Next slide, please. There's evidence also for the long-term benefits of this, and health-related quality of life is maintained in studies over at least 5 years. Next slide, please. One area where robotics really comes in a magnified, stable 3D view is in a Hemant cardiomyotomy, where you're dividing the muscle but preserving the less than 1 millimeter thick mucosa. And there are studies that demonstrate there's a reduced perforation in both primary and revisional Hemant cardiomyotomy with robotic surgery of a standard laparoscopic. Next slide, please. This is what it looks like. Play this click again, please. So here you can see the muscle being distracted by the two robotic hands, and then we can lift the muscle away from the mucosa and divide it. The image here is good. The image in the console is staggering. There's the vagus preserved and the muscle divided, and we then bring over the fundus, as you heard earlier, as a door fundification. Featuring with the robot is a dream. The next slide, please. What about cancer surgery? Is there any evidence that robotics help in upper GI cancer surgery? Next slide. My journey began a long time ago, 2011. I did my initial robotic training over in Strasbourg, only to find that we couldn't get on the robot when we got back, despite the initial promises, but we kept going and kept going. And eventually in 2020, we managed to get the upper GI robotic cancer program going. Next slide, please. There's data from around the world on the use of robotic surgery. In this paper in 2022 showed 860 patients. We've done 150 fully robotic esophagectomies in under 2 years. The leak rates shown here are true figures from around the world, with 33, 15, 17% leak rates, which to us were unacceptably high. Next slide, please. Next slide. So we visited some of the best units, Utrecht, Almelo, Mainz in Germany, and learned from them. Next slide. We introduced the program very cautiously. So we did almost 180 cases before we went anywhere near the chest. We started simple with anti-reflux surgery. Then we added in revisional and paraesophageal hernias, gastrectomy. And then we started to prepare the stomach for esophagectomy before ever going on to doing it. And during this time, we perfected the anastomosis that we were going to use in the chest at open surgery whilst doing the abdomen robotically. Next slide. These were the best results available at the time. So this unit in Almelo went from a 32% leak rate to a 4% leak rate. We were keen not to take 5 years to get our leak rate down to an acceptable level, and we wanted to come in at the start. Next slide, please. And these are our results. We found this was analysed at 125 robotic esophagectomies, and our leak rate is 3.2%, significantly better than open and comparable to hybrid. Our pulmonary complication rates come down massively, less than half of that when we had open surgery, and also an improvement on hybrid surgery. The serious complication rate is down by over 50%. The operation rate is down. The overall complication rate is almost half. And our 30-day and 90-day mortality is less than 1%. Next slide, please. Without compromising quality of resection, and if anything, we have a reduced circumferential resection margin. We do radical surgery. This is the left gastric, portal vein, hepatic artery, inferior vena cava, splenic artery. This is the aorta, laid completely bare, coming up to the arch, and the lung on the contralateral side. That's the atrium, and this is the stomach tube being delivered. Next slide, please. This patient has had an esophagectomy. The external trauma is markedly reduced by a robotic approach. Next slide, please. It's a team effort. This is our 100th esophagectomy, robotic esophagectomy patient, stood, dressed, ready to go home, post-operative day 6. Our use of ITU has reduced, and our median length of hospital stay is down by almost a week. The percentage of people having an ideal outcome has almost doubled. So that's a no complication and less than 14 days stay. Why is that important? Next slide. If you look at patients who've had a textbook outcome compared to those that haven't, there is an improvement in oncological outcome. There's better overall and disease-free survival if you don't have a complication than if you do. And historically around the world, the complication rate associated with esophagectomy is 60% from international centers of high quality centers. Ours is down to half that. Next slide, please. These are all the public series of robotic Ivor Lewis esophagectomy. You don't need to look at the data. The important thing is the results that we have. This is we're about to publish the biggest single unit series of robotic esophagectomy with the best outcomes published to date. Next series. We've also looked at quality of life, and the blue is robot, and the brown and pink are open. And we see a significant move towards an improved quality of life with robotic surgery. Next slide. There's less post-operative pain, so people need less strong analgesia for shorter periods of time after robotic surgery. We've also moved away from epidural anesthesia, and we use paravertebral catheters now. Next slide, please. There's also less impact. The patients are less traumatized by the procedure and have less have improved quality of life. They have less depression and anxiety after their surgery. Next slide, please. So the benefits of robotic surgery are that they're likely to return to there's less physical trauma, so they're more likely to return to their physical activities of daily living. They're more likely to return socially. They're more likely to return to work. They're less reliant on analgesia, especially opiate analgesia, and there's less lower rates of depression and improved quality of life. Next slide, please. So this is a quick view of an esophagectomy. So this is it's only a couple of minutes. So this is the stomach conduit being delivered after a radical resection. We suture the conduit up to the apex of the chest. A lot of people may not have seen an esophagectomy. This is how we reconstruct it. And with the robot, it's just fantastic. We then bring the esophagus down, make a little enterostomy. Make sure we don't trap it between the muscle and the mucosa. We divide the esophagus. Stapler from below, make a little enterotomy on the gastric tube. And then staple the two together. High in the chest. This is above the azygos arch. And V-tube down. And suture close the common enterotomy. One of the greatest difficulties with standard thoracoscopic surgery was the ability to suture high in the chest. With the robot, it's a dream. Okay, in the interest of time, skip on, please. Next slide. So where are we going next? This is the future. We can now even move on. We're now starting to move on to endoscopic robots. This is one I was trying out in Strasbourg. So you have an endoscopic platform out of which there is a camera and two arms that allow for 3D operating. Next slide, please. And again, so this is that system in use, performing endoscopic resections. They're limited to the colon at present because the platform is not quite long enough, but it will develop for upper GI. So you mark out what you want to develop, lift the mucosa from the muscle underneath, and can then cut out the mucosa. It's much easier than doing it by existing endoscopic mucosal techniques. You can even perform full thickness resections and then suture the defect closed in the bowel wall. They're all done down an endoscope. Quite incredible. Next slide, please. So first things first, primum non nocere, do no harm. We've demonstrated that we've introduced a robotic program in the most complex procedure without any harm to our patients, and actually significant benefits. So unlike this chap on the right, I have no regrets about moving to robotic surgery, and I can't ever see myself moving back. Next slide. So I'd like to thank everybody in my team, thank our patients from the youngest to the oldest, who've undergone the upper GI robotic cancer surgery. Next slide, please. And thank you for your time and attention. And if there are any questions, I'm happy to take them. Thank you.
Hello, thank you, gentlemen, for some lovely presentations. Our chair has having some slight technical issues, so if you have any questions, please write them in the chat, and I will fill in for Shaun. 2 seconds. We actually don't have any at the moment, so if anyone would like to put in some, we can easily get them answered for you. Just as a not an expert, I was very enamored by what you guys do. I take my hat off to you. It was very interesting. Oh. I'll just stay online for a few more minutes to see if anyone would like to answer any questions. It appears people are satisfied.
And silence.
Yes. Oh, no,
And silence.
just in time. Thank you for your talks. Mr. Sheth, patients with, forgive my pronunciation, I had a very different career as a ballet dancer. My patients with hiatus hernias always very interested to know exactly what they can / cannot do at the gym, working out. Normally keep advice vague on avoiding heavy lifting. How would you answer this?
So thank you very much for the question. I get asked all the time the same questions as you. I prefer to tell them that they could go for all forms of aerobic exercise. So things like cycling, maybe running on the treadmill is fine, swimming is fine. Try and avoid any kind of heavy lifting. So lifting weights or deadlifts are probably not advisable. Pilates is still okay. Yoga, I would be very careful because certain yogic postures require you to be upside down, particularly sun salutations. And if you're going to do them after a meal, you might cause acid reflux to be just coming up in your mouth, and your dentist might be a very happy person at the end of it. But yeah, I think essentially cycling, swimming, even using the cross trainer.
I think there's a big difference, isn't there, between those that have mass reflux or volume reflux and those that just have heartburn. So those that have heartburn generally have really, really good control with the PPI. Those that have mass reflux are much more difficult to control by medication alone, and often the people who benefit most from surgery. And my advice generally is, take your medication, get on with your life. If you then are not able to get on with your life, then that's a good indication to consider surgery. So
yeah, absolutely, Shaun, agree with you.
Yeah.
Oh. Leave it open for a few more minutes. If also to those that are still online, I'll just mention that you'll get your CPD certificates about a month from today, but this will be recorded and then uploaded to our HCA GP education talk, so you can always come back and look at what you've learned today too. I'll give it one more minute.
Hold on. Well, I'm trying to catch up to the last time.
No worries. Well, it looks like everyone is happy. Thank you, gentlemen, for some great presentations. As I said to the attendees, you'll get a CPD certificate in a month's time. So I'd just like to pass on wishing everyone a very Merry Christmas and happy, safe and healthy New Year. And thank you so much. Wish you a wonderful rest of the day. Goodbye, everyone. Bye.
Okay.
Bye.